Next, we're going to introduce Dr. Rachel Masch. She's currently the Executive Director of Basic Health International. She graduated from Brown University with a degree in International Relations and then went to Brown University Medical School. She completed her residency in obstetrics and gynecology and received a master's degree in public health from the Columbia University Mailman School of Public Health. Since medical school, Dr. Masch has done work in Sweden, India, American Samoa, Vietnam, South Africa, El Salvador, Haiti, and Africa, and is proud to be helping BHI in their mission to eradicate cervical cancer.
Well, thank you so much for coming today and for having us. This is kind of going to be, except for Franklin's talk, it's going to be cervical cancer all afternoon. So what we're going to be trying to do is, what I'm going to talk to you about today, is to try and see if we can help Tom avoid those situations that are so difficult to treat in low resource settings, to try and get it before the invasive cancer actually happens. So the objectives today are just to briefly describe some of the global epidemiology, which Tom already did, so we won't spend too much time, but then summarize some of the potential point-of-care technologies that BHI has been using in the field to try and see, I'm going to go through some of the steps of how that happened and to try and see if that can spark any interest or discussion among you guys in terms of ideas that you might have about how we can make that better, faster, easier, less expensive. Those are sort of all of the things that we hope to do in the most ideal kind of point-of-care testing. So, all right, so human papillomavirus, one of the most commonly sexually transmitted diseases in the world. Most HPV infections, when someone is exposed to them, they are transient and resolve within about 6 to 12 months. There are about 15 cancer-associated carcinogenic or high-risk subtypes or genotypes of the HPV, of the human papillomavirus, and it's the persistence of those high-risk genotypes that actually cause cervical cancer. I think Tom went into that well in his talk. It's amazing that Tom and I have exactly the same slide, shocking, but you can see that the HPV prevalence worldwide is mostly in Africa and in places where I work, which is Latin America and the Caribbean, Southeast Asia. Those slides that you showed, Tom, were amazing because the prevalence of, I liked his sort of the Museum of Fine Arts sort of representation of all those colors, those pictographs, but the burden of cervical cancer, 85 to 90% of it is in low resource settings. So that is our responsibility to try and figure out how we can do this. And cervical cancer prevention is where we need to go. Cervical cancer, I think the reason there's so much interest in cervical cancer is it is really a cancer that we can eradicate. We know the single causative agent of cervical cancer, which is HPV. We actually have a vaccine against cancer that can help prevent almost now about 90 to 93% of cervical cancers worldwide. And there is a very long time frame from exposure to invasive cancer, about 10 to 20 years, on average about 15 years that we have to try and catch someone before they get to the place that makes it so difficult to treat. So the vaccine, if we can give it to boys and girls and boys I should say, before they are sexually active, because we have to catch them before they have their sexual debut. We can prevent, again, about 90 to 93% with the new the vaccine that prevents or vaccinates against 9 of the types of HPV. But if we miss that, then we have the chance to do secondary prevention with screening, and that is detecting HPV and trying to identify and treat those women in the pre-cancerous stages. So primary prevention, obviously what we should all be striving for. There's lots, I'm not going to talk about that today. That's a whole nother talk. But secondary prevention with screening for those women that don't get that vaccine, but we have an opportunity to try and catch in a precancerous stage. So now we can screen with HPV. actually testing for the virus itself. And with HPV tests in general, the numbers look good. The sensitivity is about 85 to 90% with a negative predictive value that's great, about 98%, which can give us reassurance that those women with a negative test will not develop cancer in the next 5 to 10 years. The problem with many of the HPV tests, however, is that the specificity is somewhat low, meaning that about 15 to 20% of women with a positive test won't actually go on to develop invasive cervical cancer. So we know that we overtreat a lot of women, which is a problem not only for cost, but for inconvenience, for discomfort, et cetera, et cetera. So if you're thinking about point-of-care tests, let's try and, we want high sensitivity, high specificity, a great negative predictive value, low cost, easy to use, don't need a lot of training. These are, right, this is easy to do. We can figure that out among ourselves with our collaboration. Obviously, it's something that we're all striving to try and achieve. These HPV tests, Tom talked about the option for self-sampling, self-collection, which does remove one of the big burdens. There's a lot of embarrassment. Everyone talks about, in low and middle income countries. Well, as an OB/GYN, I can tell you that that is worldwide. There is, if you could avoid, when I talk to people, they're like, wait, there's a possibility I don't have to go for my GYN exam? Score. Sign me up. That's awesome. So it's not just in low and middle income countries. I think that is a universal feeling among women. There is only one currently low-cost, commercially available HPV test right now, and that is something called the CARE HPV test. And this is the machine that is, you can see that it's quite small and transportable. CARE HPV was developed through a collaboration with PATH and QIAGEN and funded by the Gates Foundation, and it can detect 14 of the HPV carcinogenic subtypes. On this plate that was over there on the, it's down at the bottom of that slide, you can run up to 90 samples at one time, and it takes about 3 hours to process, which is markedly faster than what we had previously. It doesn't require water nor refrigeration, and you can use this CARE HPV test in self-collection, self-sampling. El Salvador, the country where we have one of our offices, actually was the first country in Latin America and the Caribbean to receive a donation of this CARE HPV test. And we, Basic Health, decided to start a project that had 3 phases to try and see about the implementation of this low-cost CARE HPV test and whether or not it was possible to do as we scaled up in the different phases. We started with phase 1. We had 2,000 women to try and see about testing 1,000 women in each cohort. There were 2,000 women total. The cohorts were either, if all of those HPV positive women were either randomized to receive a see and treat strategy versus a colposcopy biopsy management strategy, which was the gold standard in that country. So we wanted to see if we could define an algorithm, a treatment algorithm that would go along with the CARE HPV testing. I'm going to go over the results in a second. I just want to talk about the different phases. Phase 2, we increased the number. We screened an additional 8,000 women in those same 4 municipalities in El Salvador, and again confirmed that trying to see about systems improvement and how we could scale up even further. And in phase 3, which we are completing at the end of this month actually, we did an additional 20,000 women. We're up to about 18,000 right now, which is about 20% of the country. And our goal is to try and have the Ministry of Health of El Salvador take this over and screen the rest of the country. So, obviously before an implementation project of this size begins, there is a lot of things a lot of work that needs to get done around education, training, capacity building, new information systems. The Ministry of Health we actually have HPV testing now on their national screening guidelines. And then a lot of patient education, which means that we needed to educate a lot of health promoters and healthcare workers to try and help educate patients, particularly for the self-collection and self-sampling part of the study. So what did we find? Well, from phases 1 and 2, we've realized that this low-cost HPV test implementation program was highly successful. We realized in the first 2 phases that the screen and treat paradigm was much more efficient than the colposcopy biopsy management paradigm. We realized that the highest risk women actually had the lowest completion rates, but that if we were to do active management, we could significantly improve follow-up for all women. And based on these findings, the decision was made to use the screen and treat strategy for phase 3. So as of yesterday, these numbers are from yesterday, there were just shy of 18,000 women who were screened with this low-cost test. There was about a 12.4% HPV positivity. Of those women who were positive, about 78% had visual triage, where we looked to see if they were cryotherapy, which I'm going to talk about in a second, cryotherapy eligible. And of those, 84% received immediate cryotherapy, with about 16% being referred. They were not able to get cryotherapy the lesion was too big, there was cancer, several reasons that we refer them out. So about 16% were referred. And the plan is actually to move forward with countrywide screening. Okay, so CARE HPV, however, is not truly what I would consider a point-of-care test. The machine needs to run with 90 samples in order to be the most cost-efficient that it could be. So you can freeze samples, and we did freeze samples. You can freeze them up to about 3 months until you get 90 samples so that you can run the machine and be the most cost-efficient. But obviously 3 months is not what I would consider point of care. Most women get results in about 2 weeks, which is better than what we've been doing. But again, how nice would it be to have something like a pregnancy test where you urinate on a stick and 3 minutes later it comes back positive or negative, and you can then just go right forward with with treatment right there. So better. This screen and treat strategy is good, but not ideal. Some challenges that we had, these are things for everyone to think about in the engineering world. We had shipments from China of this CARE HPV test. If you see this, this right here, that if you see right below, I don't know if you can see, but right here there's a peaking of like it's orange here and up here. This label was stuck directly over the instructions on how cold this needed to be. So when these 10,000 CARE HPV tests arrived in El Salvador, they were room temperature, and that was not good. So 10,000 tests were wasted, and we had delayed the research and delayed our screening, and what a waste of money. If only I could tell you that happened once. This happened twice. So I know. So these are things that we all need to think about in terms of how we can. This is seemingly so simple, but how can we make that better? There were also machine failures in the field that delayed the research project. We had to get the team down there to try and figure out how to fix the machines. And then maybe something you know about, Tom, in Rwanda, QIAGEN actually donated a bunch of kits. But the kits have the reagents and the vials, but they don't have the consumables like the cytobrush or the pipettes or the pipette tips. And so they needed to get that. They didn't have the program sort of in place yet. And these kits have expiration dates. So you have to use them within a certain amount of time. And almost all of those kits almost, not quite, but expired before Rwanda was able to use them. So these are all things that really shouldn't be so hard for us to try and figure out how to make better, but these are real challenges that we encounter in the field. All right, so that's screening, and I know based on the brochure that there's some exciting work for true point-of-care tests that are even faster and less expensive. But no screening program really is going to be effective if we cannot have effective and affordable treatment. So I'm going to talk now just about 2 treatments that we are testing out in the field to try and make it faster and easier and cheaper to treat women who have HPV positivity. So cryotherapy, which is the most commonly available form of ablative treatment and the only one that's actually recommended by the World Health Organization, works with cold. It freezes cervical cells. It is relatively inexpensive and simple to do, and it can be performed not just by physicians, but by trained providers, nurses, midwives. We do have lots of questions still, though, about cryotherapy. How long should the freezing be? Should it just be one application? Should it be a double application? There's cryogen gas that's used. Should we use, what's better, nitrous oxide, carbon dioxide? What is the shape and size of the tips that we are using to put on the cervix? Is there one tip or size that is better than another that will help treat and make sure that we ablate the cells that we need to ablate? And then how deep, the depth of necrosis means how deep do these treatments go so that we know that the cells that are affected, we're getting to those cells. So these are all questions that remain, even though cryotherapy has been around for decades. There are other challenges that we have in the field. We have this tank here that is really heavy and difficult to transport. It's also very expensive. Cryogen gas typically is very expensive, and because it's compressed gas, it is potentially dangerous to transport. People lay it on the sides. We work in a lot of hot places. All of these things make this particular type of cryotherapy challenging. All right, so we had an NIH grant that we were testing. It was a medical industrial partnership, somewhat, I hope, like what may come out of this afternoon's meeting, where the cryopen, which was originally used, it was cryotherapy, so using cold, and originally used for dermatologic purposes, but then was reconfigured also for the cervix. And we wanted to develop an LMIC, a low and middle income country adapted cryopen that was built to be low cost, user friendly, effective, and more durable than the one that was already in existence and FDA approved. So we had the cryopen device. We got a lot of feedback from people who were using that, the GYN cryopen device in the field, and to see what were some of the issues that they found with it, what could we do to make it better. We wanted to demonstrate clinical utility by completing a depth of necrosis study with 125 people, and then that was the first part of the NIH grant, and the second part was to then compare that cryopen with conventional cryotherapy for the treatment of CIN 2+, and that was in 770 women. So what we did with the cryopen is we tried to simplify its design. We tried to, there in the middle of the procedure, you had to hold your hand steady and take out one of the copper cores and then replace it with another copper core. We said, that's crazy, that will never work. We should just get something that we can just keep inside. We wanted to make it more portable. It was somewhat cumbersome, and now it's in something that looks like a toolbox. We wanted it to be easy to clean. With high-level disinfectant. We didn't want to have to use an autoclave. Those are things that increase expense. And people complained about the visibility, so we wanted something that would enable us to see the cervix better. So we made a clear plastic shaft that covered the copper core rather than having it be opaque. The copper core became larger, which enabled us not to have to swap it out, and it reached really good temperatures. You need about minus 50 degrees Celsius at a minimum to ablate the cervix. Nitrous is about 89 degrees Celsius. Carbon dioxide is about 68. So this certainly achieves cold enough temperatures. We did some bench testing with ballistic gelatin, comparing the the traditional cryotherapy with the cryopen, and you can see that based on these ice ball dimensions, which are just surrogate markers for how much it actually freezes, ballistic gelatin actually works as a good surrogate for the cervix for cold, but because it's gelatin, jelly, it doesn't work so well. I'm going to talk a little bit about heat. That doesn't work so well, ballistic gelatin. But anyway, it performed well against the Wallach, the traditional cryotherapy. So we are going to continue enrolling. We're starting the second part of this grant, and we are going to try and compare the cure rates in women with CIN 2+, that's cervical precancer 2 and 3+, just before the invasive cancer, treated with carbon dioxide versus the cryopen. And at the end of it, we have colleagues here in Boston at Harvard actually that are going to do a cost effectiveness analysis to see which of these treatment paradigms actually make the most sense in terms of their cost. And I can tell you that all of the science that we do with this medicine is fascinating to me and to us as clinicians, but when you talk to governments, the thing they want to know first and foremost is how much does it cost? And if we have shown, the reason why El Salvador was an early adopter is we were able to show them the cost savings that they would have by doing an HPV screening test and a see and treat paradigm. So this is from one of my colleagues in Haiti, actually, this amazing guy, Dr. Augustin, who, when I asked him about what did he find was good about this cryopen, and he said, well, usually for a period of 2 months, we use 3 tanks of nitrous for about $280 US each. But since we started using the cryopen at the Manitan Clinic in June of 2015, we just have to keep 1 tank full just in case. But that means that in 11 months, we've saved more than $4,600. And those dollars went, because they're also in Haiti, there's no radiation therapy. So when we have women with cervical cancer, we need to send them to wherever, but the closest place is the Dominican Republic. So that savings helped women get to the Dominican Republic for radiation treatment. It helped buy medicine and supplies. And it helped employ a data clerk to maintain an EMR so we could keep track of these women. So $4,600 might not sound like a lot to us. It is potentially life-saving for many, many people. That's a lot of money in these areas. Okay, I'm going to briefly talk about another treatment device that we are researching called the thermocoagulator, which uses heat instead of cold to try and ablate those same cervical cells. And it was used a lot in England and the UK, but stopped being used so much in after 1990. But it is once again gaining popularity after a meta-analysis was done in 2014 that said that it actually is a really good form of ablative technology. It's effective and safe, and the thought was that it would have real potential in low and middle income countries. So WISAP is a German engineering group that is actually reforming and overhauling this device for the first time since the mid-60s. There's also another device by Liger that uses heat instead of cold. So we wanted to adapt this thermocoagulator to an LMIC environment, a low and middle income country environment. So we wanted to make it small. We have now this new prototype is the size of an electric toothbrush. We want not to have autoclave to clean it. We wanted to be able to have it run not with electricity. It has an external battery pack. We wanted to simplify the whole thing so that it would have a single tip and a single temperature and obviously be portable and durable. This is a list for those of you who have engineering backgrounds of things that would be great to have in a low-cost, effective treatment device adapted for low and middle-income countries. With thermocoagulation, we also have many questions. We don't know for sure how long we need to treat. We don't know at what temperature we need to treat. We don't know if we can do a single burn or multiple burns. And we don't know about patient acceptability. This has been used with almost no data to support its use. So in addition, we don't know about, and I'm going to show you just a quick study, but our initial preliminary studies of depth of necrosis with the thermocoagulator, small n of 25, but doesn't seem to be as good as the cryopen or the traditional cryotherapy. Also, we don't have any trials that demonstrate that it actually clears high-grade precancer, and it is not yet recognized by the World Health Organization as an option for treatment. So one of the things that we needed to do, first and foremost, and we're going to be wrapping up in a few minutes, but I just wanted to show that some of the things that we think about is the CIN3, which is advanced precancer. So before it gets to the invasive cancer, how deep does that CIN3, cervical intraepithelial neoplasia, how deep do those dysplastic cells get? We didn't know that answer, but it's important to know that because we need to know if we're testing out different devices, we need to see if they're achieving that depth that will actually help us ablate that cervical precancer. So we looked at 107 cases that were confirmed to have CIN3 by 2 different pathologists, and we saw that about 90% of CIN3 went to about less than 3.5 millimeters. So we knew that any device that we had we would need to have it go at we wanted it to go at least 3.5 millimeters so we could achieve the best kind of cure rates in terms of precancer. This is one of our pathologists working with Dr. Taxa in Peru at INEN. And then, so the depth of necrosis study, once we figured that out, we then wanted to test the cryopen versus traditional cryotherapy versus the thermocoagulator to see how deep those went, and if we could answer some of the questions that I had discussed before. So we took women who were going to be getting hysterectomies for other reasons, and we randomized them to receive one of the 5 treatment arms. The following day, they had a hysterectomy, and then we checked out the depth of necrosis on their hysterectomy pathology, on the actual cervix that was removed from them. The 5 study arms, we wanted to see, is it a single freeze or a double freeze with both the traditional cryotherapy and the cryogun, and then one single application of the thermocoagulator. And as of the results to date, we have, of the 125, we actually have about 121 now, but these are the data that's been analyzed, and it shows that the cryopen and the traditional cryotherapy do well in terms of depth of necrosis, but the thermocoagulator is lagging a little bit behind. So we're going to continue with this study because we really don't have any other data, but we're going to continue just to try and see if that really is true when we increase the number of women that are getting this treatment. It also showed, this study, that the pain of thermocoagulation was significantly higher with the heat technique versus the cold. And so we're going to explore that a little bit more too, because obviously any treatment needs to be acceptable to patients and needs to be effective, or else it won't be any good. So just as my summary slide, cervical cancer is preventable, and we know how to do it. As Tom said, we have the ways and means, maybe not the means. We know what we have to do. We just have to figure out how to get those things to the people who need it the most. HPV testing with immediate treatment is an effective paradigm in low-resource settings, and new treatment modalities, and I'm going to leave that to you guys, the engineers in the room, to hang out with us and clinicians, and maybe together we can come up with a plan on how we can eradicate cancer. We can eradicate cancer in our lifetimes, our kids' lifetimes maybe, but it is possible. We know how to do it. And this one, I think we should go for. So thank you so much. I'd be happy to take any questions.
All right. We have one question. There we go.
Yes.
Energy storage, how much would batteries help? And if so, can you give us, volts and watts? You
No,
mentioned
I
not
think-
wanting to plug something into the wall.
Yeah. So one of the slides I didn't show is the cryopen. Most places have a truck of some. Oh, sure, sorry. One of the slides I did not show was that the cryopen can actually be charged with a car battery. And most places have some vehicle with a battery in it so that we can, you have a renewable source. We're obviously looking into solar. I think the devices the cryopen's a bit too big. So when we talk to the engineers about trying to get the cryopen to be able to be recharged, their battery recharged by solar, it would have made it really expensive. But the thermocoagulator is much smaller, and that's a possibility. So we're trying to move away from volts and use things that are already existing in communities, or the sun, or some other alternative forms of energy, so that we can decrease costs and make sure that those renewables can continue.
Okay, let's thank our speaker. And our last